controls how fast you are. And you can see that improves from pre-transplant. The seconds it takes to do it keeps improving, whether you're using the right hand or left hand. Next. If we look at cognitive tests, such as memory, PACET, paced auditory serial addition test, you listen to a recording, you have to give the answer, you have 3 or 2 seconds to do it, here's the 3-second result, and that's the percent correct. And you can see over time, cognitive function keeps improving. And I've had many patients tell me that the MS fog goes away after the procedure. So, MS is a disease that seems to tend to affect, very functional people, and so we've transplanted lawyers, politicians, people who have to use their cognitive abilities, and they're losing that abilities. And after the procedure, they get better. Next. 25-foot timed ambulation, that's how long it takes to walk, 25 feet, that keeps improving. Next. And then we always look at quality of life, SF36. And you can see the SF36 score in red, that's the median before transplant, and then in blue after transplant going out 4 years. There's marked improvement in quality of life. Well, it kind of makes sense. If you get neurologically better and you don't have to take any medications, your quality of life improves. What's interesting, and I didn't know this till I searched the literature, is all these drugs, whether it's Tysabri or Lemtrada, Gilenya or Tecfidera or the interferons, all the drugs out there, whether it's in the New England Journal or Lancet Neurology or Lancet, they never report quality of life. Never. The reason they don't is their quality of life does not improve. So if you will look and find in the obscure journals where they put the report in, the quality of life does not improve with standard drugs. But with transplant, one-time treatment, quality of life improves. Next. If we looked at the MRI, what you can see, the dot on the top is the volume of disease on MRI. The line going down where it ends is the volume of disease in that patient with our last follow-up MRI. So you can see there's marked improvement in the volume of disease. There's a 30% reduction, about a third reduction in the volume of disease in the brain after transplant. And no drug has ever been shown to do that, which correlates with quality of life. It correlates with EDSS. Next. If you look at relapse-free survival, we weren't perfect. We did have some relapses, but the majority do not relapse. Next. Progression-free survival, same type of thing, not perfect. Progression occurred because in that subset of 150, we had about 22 early secondary progressives. And that's, again, where you have to be careful. Next. So if you look where the details are important, the EDSS for relapsing remitting in blue versus secondary progressive. Now I said don't do late secondary progressive. Don't do it. But you will get some patients, and it appears like they're in early phase of secondary progressive, and they'll want you to do it. And about half of them get better and half don't. And if you look at the median of them all in red there's no improvement. That was about 22 patients of the 150. The majority are relapsing and remitting, and those are the ones that really get better. Next. If we looked at disease duration, if they've had MS for more than 10 years, in red, before the transplant, they tended not to get better. If they had it less than 10, which is in blue, which was the majority, they got better. So I figured the longer duration of disease is just a marker for secondary progressive MS. We're looking at the same thing. But in fact, in multivariate analysis, they were independent predictors. So long duration of disease or secondary progressive MS really won't do good with this treatment. And I see that, and you'll see that in the registry because they don't clarify it. Whether, they'll have someone with 15 years of MS and they're 50 years old. I don't need to hear anymore. They're secondary progressive, and they're not going to do well. That's the danger of registry data. Okay, next. If we look by age, if it's really relapsing remitting, some people that are older are relapsing remitting, you'll see they all improve, even up to age 58, which is the red line on the top, they get better. But of course, the younger people, 18 to 25, do the best. But you can still treat older people if they really are relapsing remitting. However, most relapsing remitting are younger people. 90% of MS at onset is relapsing remitting. By the age of 40, only 40% are relapsing remitting. So be careful as they get older, that you're choosing the right subset of patients. Next. This, where I talk about patient selection being important, regimen being important, standard of care is very important. And this is the only disease we've seen this in. We transplant a lot of autoimmune diseases. Fever during transplant gives bad late outcome. So if you look, if we had a sustained fever greater than 38.5 or 38.5, which is the orange and red line, you will see by 2 years later their EDSS is worse. Higher numbers worse. They're not doing well. If they didn't have sustained fever, they got better. I think just fever is bad on neurons that are demyelinated, and it accelerates this axonal degenerative phase of the disease that occurs later. That fever was never, ever due to infection. We never got a positive blood culture on any of the 150 patients. It was due to ATG. So as soon as a patient, when you're treating with Cytoxan ATG regimen, gets a fever, what we do is we give them Solumedrol, and we broaden antibiotic coverage, cefepime and vancomycin, and we draw cultures. A few hours later, they feel terrific. It's never been sepsis. It's always ATG. But the thing you don't want to do is treat them like a cancer patient where you let them sit and cook with that high fever while you're doing CT scans and cultures and you're afraid to give them steroids because you think they're infected. They're not. And they will do worse later. Next. So just remember this. Fever is always due to ATG. I can't say always. There may be a bacteremia. But this is how we approach it. The fever due to ATG usually occurs between day 0 and day 6. ATG is in your conditioning regimen before day 0. We give steroids before ATG when we give it, so we don't get fever then. This is a late ATG fever. When it occurs, we get a preemptive antibiotic coverage. We also give Solumedrol, 250 milligrams, the next day 125, the next day 125. We add vancomycin to our antibiotic coverage, and we draw cultures. The cultures are always negative. And you'll see a patient with MS, when they get fever, they just look terrible. They can't move. And you think there's some terrible flare of MS. It's not. It's a pseudo flare with fever. You don't need to do an MRI. They now can't move their extremities, or they're falling, they can't walk because of the fever. They're not having a flare of MS. Within 2 hours of Solumedrol, they're up smiling, walking. Okay, next. Now, is transplant cost effective? A non-myeloablative transplant with Cytoxan ATG, unmanipulated peripheral blood stem cells, in America is $125,000. It is a lot of money. Most American insurance companies will pay for it. Why? Because if you look at the cost of just drugs, and that's published in Neurology in 2015, not by us, but by neurologists, and those are 2013 prices, so they're going to be a lot more now in 2017. But the cost of every drug is about $59,000 to $66,000 a year just for the drug. Now they're running about $75,000 a year, $80,000 a year just for the drug. That is not the physician fees, not the hospital fees, not infusion fees if it's IV, not MRIs, not blood monitoring. That's just the drug to the drug company. So you can see a transplant, which seems to give much superior outcome and is a one-time treatment, will be cost effective in about 15 to 18 months or less. Anyway, if you go to that journal where this is published in neurology, the cost in America with drug therapy to prevent one relapse is $80,000 US. That's ridiculous. So insurance companies in America are starting to figure this out and are more rapidly approving our transplants because it ends up saving them money. In fact, Lemtrada, which was not in this paper, Lemtrada, just the drug, is $156,000 US in 1 year. That's more than transplant. Next. So I started with a quote from Dr. Osler. Here's a quote from Socrates. The secret of change is to focus all your energy not on fighting the old, but on building the new. And that's what transplant does. It builds a new immune system. We've shown that in animal models. We've showed it in patients with lupus and patients with MS. That's why our clinical data is so good. Next. So, next. What I want to show you there is 3 studies. The study by myself in yellow of 151 patients we reported in JAMA, the Swedish study in blue of 41 patients, and the HALT trial from the Fred Hutch of 25 patients. And if you look at NEDA, N-E-D-A, that's no evidence of disease activity after transplant. No relapses, no progression of neurologic disability, no new lesions on MRI. Surprisingly, we're all the same. So those are 3 non-randomized trials, but they're one regimen, experienced centers, they're getting the same results. Our regimen's actually different than theirs. We use Cytoxan ATG, the Swedish use Cytoxan ATG, the Seattle people used Beam, but the results are the same. So on this bottom, that's the data for NEDA, no evidence of disease activity in MS for drug therapy. Look at the difference. So even natalizumab or Tysabri, at 1 year it's 50%. No evidence of disease activity. That drops to about 38% at 2 years. So there's a tremendous difference between transplant and all the drugs out there in terms of no evidence of disease activity. After treatment, remember transplant's one-time treatment, and these drugs, people just stay on them. But the caveat again is the transplant data is not randomized. Next. So, we designed a randomized trial, the multiple sclerosis international stem cell transplant trial, or MIST. It's headquartered in Chicago at Northwestern University, but we ran it at the University of Sheffield in the UK, the University of Uppsala in Sweden, São Paulo, UPSI, the University of São Paulo in Brazil, and of course, our own center in Chicago. What we compared was transplant to the standard of care, best available drug. Now that's unique because every single drug trial compared the drug, whether it's Tysabri or Lemtrada, alatuzumab, or Gilenya, or Tecfidera, or an interferon, they compared it to a placebo, nothing, or to interferon, or Copaxone. That was it. We compared it to all the drugs out there, mix and match, however the neurologist wants to do it. So patients got Tysabri on the control arm, they got Rituxan, they got Cytoxan, they got IVIG, they got Gilenya, Tecfidera, Aubagio. No drug has ever done that. Why would they want to? Why would Tysabri want to compare itself to Gilenya? It's a lose-lose for some drug company. So they always compare first to nothing and then to just Copaxone or interferon, the weakest drugs. That's what they've all compared to. We compared to all the FDA-approved drugs out there. Now, at the time we ran the trial, Lemtrada wasn't yet approved, so there was no Lemtrada. But every other drug they could use. Mitoxantrone is approved by the FDA. I don't like it, but some people got it on the control arm. So we had I think, neurologists will complain. You can always complain about any study, and they'll say, oh, you didn't compare to one drug. But we actually compared to what the neurologists do out there to any drug they want to use, and they could change drugs, which no MS study's ever done. And all our patients to get in this trial had to have failed interferon and Copaxone. They had to have failed it. And then they could continue with whatever neurologist wanted to treat them on, or they could go to transplant. The problem is patients are on the internet, they talk to each other, and our transplant patients were doing good, and the drug-treated patients weren't. Nobody wanted further drug treatment. What saved the trial is if they progressed by EDSS, after at least 1 year of drug treatment, they could cross over to transplant. So the primary endpoint was failure, increasing EDSS by 1 point, which is the primary endpoint of almost all trials in MS. If they met that, and that was sustained for at least 6 months, and they had at least 1 year of therapy, they could cross over to transplant. And that's what saved the trial. Next. Now, since they could cross over after 1 year if they're not doing good, it's hard to compare any data after 1 year because all the bad actors on the control arm are crossing over to transplant. But up to 1 year we can compare, and what you can see is that the transplant is in blue. And they started with an EDS of 3.5, and by 1 year they're 2.3. They're doing exactly the same as our JAMA paper. Their neurologic disability improves. If you look at the drug therapy, which again is any drug neurologist can put them on, they got worse. EDSS increased from about a 3.3 to a 3.9. And that's highly significant. But they did what drugs do. They slow progression compared to nothing or compared to just now interferon. So they continue to progress in their disability. And this EDSS was not done by me. It was done by a blinded evaluating neurologist who had no idea what regimen they were on. So we had a treating neurologist for the drug therapy who would treat them however they wanted to treat them, and then we had an evaluating neurologist for both arms that didn't know which arm they were on. So he was blinded. We haven't yet published this data, but we've completed the trial, and I need to get started on writing it up. Next. Importantly, if we look at failure, failure is an increase, that was the primary endpoint, an increase in EDSS of 1 that's sustained. On the drug arm, failure's in red. On the transplant arm, we designed this was 110 patients, 55 in each arm. If you look at most randomized trials, there are at least 150 in each arm. The reason there's so many in a randomized trial is because the difference between the two arms in terms of treatment is thought to be very little, so you have to do a lot of patients to get significance. That's called equipoise. It's the catch-22 you're in when you do a randomized trial. If one arm's much better than the other, it's not ethical to offer a randomized trial. They have to be similar, and that's equipoise. So no group of patients are getting inferior therapy, which means you have to do a large number of patients to pick up small differences in benefit. And that's what most trials do. We assumed that transplant was markedly superior. So we only did 110 patients. We predicted it would be markedly superior. In fact, it was. Our prediction, our statistical prediction turned out to be correct when we got the actual data. We could do it with only 55 in each arm, 110 patients, and see a highly significant difference, because one was superior to the other. But then how do we get around equipoise if we're offering a much more superior treatment in one arm than the other? The way we got around it is, in the drug arm, you can give anything you want to give, mix and match and change according to how the patient's doing. And if they do bad, if they fail, they can cross over to transplant. That's how we got around the question of equipoise. And as you can see in the transplant arm, of 55 patients, one we withdrew because before transplant, the patient had problems with urinary retention, which MS patients have, got urosepsis and got osteomyelitis. But that was before the transplant, but after randomization, so we did not proceed with transplant. The patient was withdrawn. And then 2, in one of the early centers that I removed from this study, the first 2 patients they enrolled were progressive, secondary progressive. Despite all this talk, don't do that. That's what they did. So we just censored those patients and removed that center. So we have 53 patients in the transplant arm. In the control arm, there were 55, but I really need to drop that figure for final publication to 50 because 5 patients in control, 2 that were randomized to drug therapy, just up and left and went and got transplants in Russia or somewhere. 3 went with drug therapy, but they got worse. And when we told them, no, we can't transplant you yet. You have to have sustained increase in disability for at least 6 more months. They said, forget you, and they left. And they got a transplant. So we lost 5 in the control arm because they went to transplant somewhere else. Even knowing that if they stayed with us and we had sustained disability, they could cross over. I can't blame the patients. Obviously, we're disappointed, but I can't blame them for what they did, and that's why when our data comes out, it's going to be even harder to run a randomized trial. So if we drop to 50 patients in the control arm, and there are 28 that had failed, actually now there's 31 that have failed, and there are 2 more that are waiting for another 6 months to determine if they failed. I'm sure they'll fail in 6 months. We just can't call them a failure yet. So the overwhelming majority in the control have failed, only 3 in the transplant failed, and they were weird failures because their MRIs didn't get worse. No new lesions, but their disability got worse. So one of them, where the main disability was ataxia, we looked for mutant genes, spinocerebellar ataxia genes, known to cause genetic ataxia, and we found the patient had them. So I think there's a small subset of MS patients where the demyelination is secondary to a genetic process. But the vast majority, the demyelination is immune mediated, and if we reset the immune system, they get much better. That's what that data is telling me. Nevertheless, the difference in failure between the 2 arms is at around 10 to the -7th. Highly significant p-value, 10 to the -7th. I'm sure the journal will say we have to just say the p is less than 0.001, but it's a highly significant difference for a small number of patients. Next. So this is some of my team at Northwestern, and I think, everybody in my team does this with a certain passion because we know we're doing something that the rest of the world hasn't caught on to yet for MS, and that is we can reverse neurologic disability, improve quality of life, and make people drug-free for very sustained periods of time. You have to select the right regimen, you have to have the right selection of patients, and you have to understand standards of care, like avoiding fever. Now, in patient selection, you not only want to get relapsing remitting, but patients are going to come to you and they've been on Tysabri, or they've been on Gilenya. You have to build in drug clearance before you do the transplant. And the reason is I have never had a patient get PML, progressive multifocal leukoencephalopathy, from the JC virus. 50% die when they get it, the other 50% are neurologically much worse, even if they survive. We've never seen it. I've talked to the registries. There is value to registries for that and for other things, and they've never seen PML in any of the MS transplants. So I think, and that's even using myeloablative regimens, so I think transplant's fairly safe for PML, but what worries me, Tysabri has a very high risk of PML. And if you take a patient on Tysabri right to transplant, they might get PML, and all neurologists will say it was your regimen, and they're only half right. It's the Tysabri and your regimen. So people come to us failing Tysabri with active enhancing lesions, they have to be off at 6 months. 6 months before we do a transplant. Why 6 months? Because if you stop Tysabri on patients with MS, they flare, all of them, at about 5 months. So the pharmacological half-life of Tysabri is a few weeks, but the biological half-life is 5 months. That's when they flare. That's when they explode, when they stop. And the reason they stop is they're JC virus positive and their index is going up. And that's predictive of PML. So the neurologist is stuck. They're doing good on Tysabri, but he's got to stop it, and he's scared to stop it. And the patient's scared. Because they stop, in 5 months they're going to flare bad. If they don't stop, they're very high risk of PML. The longer you're on Tysabri, the higher the risk, and neurologists will follow the index of the virus, and as it's going up,